Mary Boyle. I'm the Director of Operations here at Hope for HIE. I wanted to welcome everyone to our talk. We are going to be speaking with Dr. Sami Horani and Annie Gunning, who is our child life specialist here at Hope for HIE. So we are going to talk today about HIE and anesthesiology. Dr. Horani, if you want to introduce yourself.
Yeah, hi. I'm Sami Horani. I'm an anesthesiologist here at the University of Texas Southwestern Medical Center here in Dallas, Texas. I've been in practice for a few years now. More importantly, I'm also the father of a 2-year-old. His name is Kareem. He has severe HIE, so I kind of understand what it's like to be on both sides of the table. Um, a lot of our kiddos get surgical procedures pretty commonly. My son is 2 years old, like I said, and he's already had 2 surgeries under his belt. And anesthesia is kind of a black box for a lot of people, even for healthcare providers. So I just wanted to come on and talk about a little bit about what anesthesia entails, what are the roles of some of the providers, and then how anesthesia interacts with HIE, and then kind of some questions to think about when you're on the day of surgery with your child.
Great, thank you. And Annie?
Yeah, I'm Annie Gunning. As Mary said, I am the child life specialist at Hope for HIE. I'm also a grief counselor. But my role as a child life specialist is to help children and families understand and cope with medical experiences. So whether that is a doctor visit, or surgeries, procedures, tests, anything like that, helping them to understand, provide that education and diagnosis while also decreasing that stress and anxiety. So I do a lot of one-on-one conversations with parents and even kids, including siblings. I've done a lot of education with them just to help them understand what to expect and what is happening to them. Because in turn, if they understand what's going on, then they cope with it better. So
Great. Okay. And then Dr. Honey, you're going to share a little presentation for us, and then Annie is going to share a little bit about just what she talked about how to prepare kids for surgery and parents.
All right, perfect. I'll jump into the presentation. I'll share my screen now. Yeah, sure. And then, oh, yeah, is it working?
Yes.
Okay.
Like, yep.
All right, so I'll just proceed into the presentation. I have no financial disclosures to talk about, no relationships in the industry or anything like that. Objectives of this presentation, like I touched on, define what is anesthesiology, who are the various anesthesiology providers you might encounter in the hospital, and their roles and responsibilities, the types of anesthesia, the logistical process of how it actually works, the medical considerations in regards to HIE, and then discuss some questions you might want to ask your team, your perioperative team on the day of the surgery. So, what is anesthesiology? This is the practice of medicine, rendering patients insensible to pain and emotional stress during procedures, protecting vital functions during procedures, and managing acute, chronic, or critical care pain. This is a definition that comes from one of our governing bodies in anesthesia. Essentially, our goal is to keep your child safe and comfortable throughout their surgical procedure. Um, so, essential components, we want to make sure that they are deep asleep, that they're well controlled from a pain management standpoint, and that they're not moving so that the surgeons can do what they need to do. We closely monitor the physiology during the perioperative period. At a minimum, we keep a close eye on heart rate, blood pressure, oxygen, and temperature. And then, depending on the surgery, we can also monitor different other elements. And then we also manage any urgent or emergent situations that arise either before the surgery, during the surgery, after the surgery, either expected or unexpected. So, what are our responsibilities? Like I talked about, we assess, we consult, and we prepare our patients to undergo anesthesia. We determine what is the medical status of our patient and prescribe that plan of care. Um, we manage all components of intraoperative care from an anesthesia standpoint. That includes the induction of anesthesia, the maintenance and emergence from anesthesia. Like I touched on a little bit earlier, we monitor vital signs, we manage blood pressure, We administer all kinds of medications, whether for pain, nausea, or any other purpose. We give fluids, blood products if necessary, and then we also perform other more specialized invasive procedure as needed if the surgery requires it. And then we also evaluate and treat any issues that pop up in the post-anesthesia period. So who are our team members? So there's three kind of main team members that you might encounter from the anesthesia. An anesthesiologist is a physician who has undergone specialized training in anesthesiology, like myself. This involves an undergraduate education, 4 years of medical school, 4 years of residency training where you are doing anesthesia day in and day out as a practicing physician under supervision. And then there are some fellowship options in anesthesia, cardiac anesthesia, pediatric anesthesia, and so on and so forth. There are also nurse anesthetists, also called certified registered anesthetists or CRNAs. These are nurses who have undergone advanced training in anesthesiology. So they have an undergraduate nursing degree, 1 to 2 years of critical care experience, and about 3 years of CRNA school. And then there's also another group of people called anesthesiology assistants. These are non-physician anesthesia providers with advanced training in anesthesiology. These are not present in every state in the country. I think about 16 or 17 states have them. That's just kind of based on legislation. Um, these require an undergraduate degree and then a master's program. So the way that most places work is either an anesthesiologist handles, the anesthesia from beginning to end by himself and is just monitoring that case, or the anesthesiologist supervises the CRNA or the AA and helps guide the care for that case.
Hmm.
I want to touch on the two broad types of anesthesia that we most commonly provide. General anesthesia refers to a deep state of unconsciousness with an inability to respond to a surgical stimulus. This just means that we provide a lot of medications to make sure that the patient is in a deep, deep sleep. And as a result, those medications that result in a deep sleep, they can kind of decrease your ability to breathe on your own. And so that's why oftentimes these procedures that require general anesthesia, they require some level of respiratory support, which for us is either a breathing tube, which is what an intubation is, or some other advanced airway device that helps us support the breathing and the oxygen levels to balance out that deep anesthesia.
Hmm.
There's also something called monitored anesthesia care. This is also called sedation or twilight sedation, kind of more commonly. Um, this involves varying levels of consciousness. This is kind of a wide spectrum of responsiveness and airway support, but in general, it means that the patient is a little bit more awake. They're typically breathing on their own with maybe just a little bit of oxygen or some minor support. They might be a little bit more awake, might intermittently see things, hear things, but they're not completely deep asleep.
Hmm.
So, what are the logistical steps of care that go into our workflow as an anesthesiologist? So, preoperatively, we typically receive our assignments, the night before, or sometimes if it's like a special case, we know it in advance, more in advance. We review the patient characteristics, their whole electronic medical record, their medical history, what medications they're on, whether they've undergone any surgical procedures before, any issues with anesthesia in the past. We review what the operative procedure is, and we know what the operation is specifically so that we can know what anesthesia for us to provide and what additional things we need to do.
Hmm.
On the day of surgery, we interview the patient, we interview the family, we confirm, what procedure we're doing, the medical history, if any changes have occurred, and then we'll discuss what the plan of care is. Intraoperatively, once it's time to go to the operating room, we will escort the patient to the operating room. We will apply monitors on the patient, so our EKGs and our blood pressure cuff and our oxygen monitor. We'll provide oxygen to the patient to fill up their lungs with as much oxygen as possible, and then we'll send them off to sleep by inducing anesthesia. We'll perform any necessary procedures, whether that's placing a breathing tube, placing other IVs, and other things that we're capable of doing. We'll actively monitor throughout the procedure as the surgery is ongoing. And then once the surgery is done, we wake them up and then we take them to the recovery room. And then once they're in the recovery room, we manage pain, their hydration, and any other issues that might arise until the patient is awake and alert and ready to go either home or if they're going to be admitted into the hospital, up to their hospital room. So I want to talk a little bit more about induction of anesthesia. Again, this is when we administer our medications to put the patient to sleep. There's two primary methods that we do this in. We do this. IV induction is one, and the mask induction is the other. The IV induction is typically our more common and preferred method. This is when we, are able to place an IV in the pre-op area before giving any medications. And then once we have the IV in, we escort the patient to the operating room and we put them to sleep, kind of as we touched on before. However, it's in certain situations, like a lot of children that are not able to tolerate placement of an IV pre-op, because of anxiety or they're scared, which is totally normal. We'll do what's called a mask induction. This is when we'll administer some anxiety medications either by mouth or by G-tube. We'll take them to the operating room. We'll give them some anesthesia gas to breathe in so they go off into sleep. And then at this point, we'll place the IV. And then once the IV is in, we'll proceed as we were going to proceed before. So again, in kind of the pediatric population, the mask induction is fairly common. I wanted to touch a little bit on parental presence in the OR. It's something that probably Andy is familiar with, and a lot of there's kind of some talk about it. This is the idea that parental presence in the OR can help alleviate the child's anxiety upon entrance into the operating room. This is very facility and patient and anesthesiologist dependent. Like for example, here at our facility, we don't do a lot of parental presence in the OR upon going to sleep, but I know that there are other places that do this fairly commonly. So it really kind of depends where you're at. Some factors to where typically it's not allowed is if there's an emergency surgery that needs to proceed, or the child is very, very young, or if the child is critically ill, then parents are typically not going to be allowed in the OR. This requires good teamwork and cooperation between everyone. So between the anesthesiologist, the surgeon, the operating room staff, and the parents. But ultimately, it really is up to the discretion of the anesthesiologist. And really, like, if it goes well, it's really great because it helps. There's nothing that alleviates a child's anxiety, oftentimes more than their parents. And so, if it does go well, it can really help make things smooth. But also, it can contribute to parental anxiety as well. Obviously, it's hard to see your child go off to sleep. And so that's why places have different kind of practices and how this works.
Hmm.
So next, I kind of want to talk about some common conditions that are associated with HIE and its implications on anesthesia. This is not an exhaustive list by any means, but it is kind of the more common things that that we see in the HIE population we have to consider when undergoing anesthesia. So from a neurological standpoint, developmental delay, epilepsy, cerebral palsy, spasticity and dystonia, also sensory impairments. From a respiratory standpoint, if there's any history of aspiration, any type of sleep apnea, or anything along those lines. From a GI standpoint, if there's a history of bad reflux, if there's a lot of vomiting, what is the feeding status, whether orally or by G-tube, and then also other things, including like contractures in terms of like positioning in the OR, making sure that we position the patient in a comfortable manner. And then it's also not uncommon for these kiddos to be a little bit tough sticks for IVs. So in terms of neurology, epilepsy is obviously one of the more common is fairly common, among our kiddos. My son has epilepsy. The good thing is that our anesthesia medications in general are almost all seizure suppressing medications. So there's not usually a big concern for a seizure to happen, under anesthesia because a lot of our medications are what we use to like kind of treat seizures, at least in the acute term. However, sometimes there are some patients that upon awakening from anesthesia, that change in awareness can lead to seizures upon waking up from anesthesia. So we
Mm,
have to be very cognizant of that as we're waking up a patient. Although there's no specific data that says they're at higher risk. But again, everyone is very different. And so, that we're getting that history is really important. And so some pertinent questions that we'll probably ask is when was the last seizure? What do the seizures look like? Are they tonic-clonic where there's convulsions, or are they a little bit more subtle with different signs? And it's important for us to know that so that, the parents are not there when the patient is waking up. So we can see if we do see these different signs, especially if they're more subtle, we can know that, hey, a seizure might be happening. We can take action on it.
mm,
And then how often do these seizures occur? Are they controlled, uncontrolled? What medications? In terms of developmental delay, this can, impact communication and kind of anxiety. Sometimes our kiddos can have a hard time expressing themselves, especially if they're nonverbal. And so we have to kind of find a good groundwork with, the families and the child to make everything as smooth as possible. And this is where, parents, they know their children very well, so they know what worked for their children, what helps calm them, what might stress them out. And this is where Annie's role it shines very brightly in this situation.
mm,
And then also these kiddos can sometimes take a little bit longer to wake up from the anesthesia inherently.
mm,
From a respiratory standpoint, there's a lot of kind of like maybe like when I say can increase complexity, like this impacts kind of how we are going to approach them in the operating room. So if there's a history of if a child has had like a lot of lung infections or pneumonias, if they have bad scoliosis, it can affect how they breathe, especially under anesthesia. If there's a lot of secretions, these are all things that for us we take into consideration for in terms of managing the respiratory status. And then higher risk of respiratory depression post-operatively just means that a lot of our kiddos, they like I said, they're a little bit more sensitive to the anesthesia. And also there's a good amount of them that have some level of sleep apnea. And so because of that, it can contribute to, them needing a little bit more oxygen, at least immediately after the surgery.
mm,
So some pertinent questions we might ask, any recent illnesses, and this is a big topic, especially in children. Children oftentimes get, upper respiratory illnesses. And so if a child has had an upper respiratory illness, within the last 6 weeks before their surgery, and it's a elective procedure or what we call kind of like a surgery that can be rescheduled, we'll oftentimes ask for it to rescheduled because these kiddos can have a little bit more reactive airways when we're putting them to sleep and waking them up.
okay.
We'll ask how much oxygen they're on, if they are on any oxygen. If the child is on CPAP or BiPAP, how often do they use it? What are the settings? These are things for us to know. If the child has a tracheostomy, how old the tracheostomy is, why it was placed in the first place, and then knowing maybe some of the details of the tracheostomy, like the size, if it has a cuff or not. These are things that help us manage what we're going to do with that tracheostomy, both during the surgery and afterwards.
Mm,
From a gastrointestinal standpoint, these kiddos can be a little bit higher risk of what's called aspiration. When we give our anesthesia, it relaxes a lot of the muscles in the body, including what's called the sphincter, which connects the stomach and the esophagus. And so, aspiration refers to if contents from the stomach come out and go into the lungs, and then it can cause some adverse effects. So, if a child has really bad reflux or really poor muscle tone, it can increase this risk of aspiration. So that's something that we take into account. And this can kind of make a difference whether we're going to, maybe do light sedation or if we're going to place a breathing tube, because the breathing tube protects against that risk of aspiration. So if someone's considered a high aspiration risk, we will place a breathing tube commonly. Sure, a lot of people are aware we have to hold off on eating before surgery, and that's to help prevent our stomach from being full to prevent this kind of decrease the risk of the aspiration. There's different guidelines for different kinds of products. So clear liquids, which is like water, juice with no pulp, is okay for 2 hours, breast milk 4 hours. We say 8 hours for any kind of solid food or G tube, where so don't eat for 8 hours before your surgery, is what we say. And then some pertinent questions we might ask. So how does your child eat? Do they eat by mouth or by G-tube? Do they have difficulty with swallowing? Do they have bad reflux? Is it controlled or uncontrolled? These are all questions that we'll ask in the, before going off to sleep.
Yeah.
So some questions that I think is pertinent to ask, from families to their providers is who are the anesthesia team members? It can be hard because, like we talked about, there's sometimes an anesthesiologist, there can be a CRNA, there can be a resident, there can be students. And so it's important to ask, like who exactly is the person that's talking to you? And if you are talking to, a CRNA or an AA, make sure you ask to meet who is the supervising anesthesiologist as well,
Mm.
so that you can know that who is truly like responsible for that patient's care and dictating the care. Um, and then knowing what kind of facility your child's procedure will be taking place is also important. So the big two places here that we have are ambulatory surgery centers versus a hospital. And the ambulatory surgery center is somewhere, it's kind of like a building on its own. It doesn't have any capability to like stay overnight. And so these are kind of appropriate for if it's a really simple procedure or somebody with not as many complex needs, but inherently there's, less resources, less support. So, my recommendation is if your child is kind of on the moderate to severe spectrum, has, some significant issues, to have the surgery done in a heart hospital. That way, if they need to spend the night in the hospital, they can sleep in the hospital. If there's extra hands that are needed for, extra help, it's readily available. Um, that sort of thing. What medications should I continue or stop prior to surgery is, a question to get clearance on, kind of beforehand. In general, in this population, we'll want to continue everything. So seizure medications, reflux medication, these are all typically good to continue. However, there are certain situations where they might want you to hold off on a certain medication. So it's always best to ask the care team, what medications should I continue? What medications should we hold back on? Um,
Dr. Horani, can I ask you a question about that one? Just for
yeah,
like speaking with
yeah,
parents, would this be asked like would the parents get a phone call before this surgery, and would they be speaking to, because sometimes I feel like parents ask questions to maybe a scheduler
yeah.
and not the medical care team, and they get, an answer from the scheduler that isn't right, because that's not their role. So who would they ask like some of these, like the medications questions? Would they get a
Yeah,
call from the medical care team or the surgical team?
yeah, that's a good question. I would call the surgical office and I would ask to speak to a nurse because they usually have a nurse that staffs the office, and that nurse will be a little bit, should be more aware of kind of like what to give, what not to give versus a scheduler. And then if they have any questions, like if there's any unclearance, you can always ask like, hey, can we, can the physician or like can the nurse touch base with the physician? Sometimes in certain situations, they can get in contact with the anesthesia team, in advance and say, hey, this patient has a question about continue or stopping this medication. Can you help us
Right.
out? So I would say like, call the office and ask specifically to speak to the nurse that's in the office so that they can have a little bit more insight on that. Yeah,
Yeah.
that's a good question. And then the last thing that I could think of, and of course, there's always more questions. Sometimes, our kids can be difficult sticks. We don't want them to be stuck a bunch of times if they're difficult sticks, and we all know if our kids are difficult or not. I would always ask, if you know that they've been poked, they always getting poked 2 or 3 times. There's nothing wrong with asking, hey, is there like an ultrasound IV team that's available? These are, more often present in like hospitals. And these are technicians who are specifically go around the hospital and place IVs under ultrasound to where they can physically see the vein and place the IV in the vein. And that way, this helps minimize getting poked a bunch of times, especially, if your child is pretty anxious, which is normal. It's something that, for my son, he can be a little bit of a tough stick sometimes. So, like for his surgeries, I have asked for this, and it has been accommodated. But again, it's also dependent on the facility if whether they have this capability or not. And a lot of times, if they don't have somebody like this IV team available, a lot of the anesthesiologists like myself, we are proficient in this technique. So you can always ask there.
Okay.
And then that's it. This is my son,
Oh,
Kareem.
He's
He
so
didn't,
cute.
yeah, he didn't get his hair from me. I can't take credit for it.
He's really
Oh my gosh,
cute.
that's
Thank
adorable.
you.
What was his name?
Kareem, like the
Kareem,
basketball.
that's right.
Kareem.
So cute. So cute. Well, thank you. That
Very
was so
fun.
interesting. Thank
Yeah, of
you.
course.
Yes, very helpful.
Yeah,
Love it.
that was great.
I'm gonna like just tag on the back of what you said with the IV sticks, because of course I do not like seeing children get stuck multiple times. One and done is always the goal.
Yeah.
And I think this was also the case when I worked a little bit in pre-op as well, but in the ED for sure. There was times when we had a kid that was a difficult stick. We'd either call our PICU team, our NICU team, and then if needed, our anesthesiology team. So there
Yeah.
are, like you said, other teams around the hospital that are very proficient in getting those hard sticks that are
Yeah.
available.
Absolutely. Absolutely. It's tough to watch, somebody get poked two, three times. So if you know that that's happened before, just there's nothing wrong with trying to stop that from the beginning.
Yeah, absolutely.
Yeah.
I mean, I loved the presentation because there were so many
Yeah.
things that, like, as you were talking about, I'm like, yes, yes, I know. Like,
Yeah.
because I worked in like the pre-op area for a while, and I really liked
Okay.
working there. And um, my job was to prepare kids while they were in that pre-op area, including the parents. So, doing the preparation for the IV. So, if you are at a hospital and you are preparing for surgery, ask if they have the child life specialist to come into that room and do prep work for the surgery, or for the IV. I was also at, like, the parental presence. So I wanted to get your take on this. I was wondering if you find it more like prevalent in freestanding children's hospitals where they are only pediatric hospitals versus
Mhm.
a hospital within that does adults and children. If you noticed a difference, or if you have found that there's a difference where it's more parental presences just in pediatric hospitals.
Yeah, it's a good. I mean, here we have a children's medical center here, which is it's a very large pediatric hospital, and they don't allow parental presence for the most part. Again, it really is kind of like up to the anesthesiologist at the end of the day.
Right.
Probably, I think what I would imagine is in maybe places that handle more complex kids, it's a little bit less
Mm-hmm.
common because sometimes putting off those kids off to sleep can be a little bit more tenuous.
Mm-hmm.
Whereas maybe in other places where they're maybe handling kind of less sick kids, they might allow it more
Mm-hmm. Okay.
because the children are generally healthier.
Mm-hmm.
But I mean, it's a good question. I know there's other children's medical centers in my understanding, that they do allow it. So
Mm-hmm.
really, I don't know what the rhyme or reason is. I think,
Yeah.
it also like depends on leadership. Like if whoever's in charge of the department is kind of pro or against it, it kind of just trickles down
Yeah.
to everyone else.
Yeah. Well, and I agree, like what you said, like everybody needs to be on the same page that this is
Yeah.
like what works, right? It can't be one or two people. So I think that's just one of the questions you can ask when you make that phone call to the hospital. And again,
Yeah.
highlighting that you're not just talking to the person who made the phone call to you to schedule and make sure you're not eating and drinking beforehand, but you're actually talking to a member of the
Yes.
medical team. And
Mhm.
you can ask them these types of questions, like, is parental presence allowed at induction? Because I think we had a member of our community that they were told it was, and then it wasn't, and so
Yeah.
it
Yeah.
just it adjusts, it changes the way you prepare yourself and your child.
Absolutely.
So
Yeah.
if that's not allowed, that's fine, but you need to be prepared for that.
Yeah.
So,
I completely
um,
agree with that.
Well, this is a very just naive question probably, but so where would be if you're not allowed into the operating room with your child, when is the last time, like when do you say goodbye to your child?
Yeah, so you'll often be housed in like a pre-op room. So
Okay.
it's a private room that is in the near to the operating rooms. And in those rooms, it's going to be the child and the parents. And then from that room is where, the OR team, the anesthesiologist and the nurse come to pick up the child. And then at that point is usually when they escort the child to the operating room. And then that's usually a lot of times when, people, will say give hugs and kisses, and, see you laters at this point. Sometimes in certain situations, you can kind of walk with the child up until kind of there's like a solid red line where it's like, okay, or personal only. Sometimes, certain places will allow that. But
Mhm.
generally, like that pre-op area is, and that's where you're seeing the surgeon, you're seeing the anesthesiologist. So you're spending a lot of time in that room. So you're well familiar. Yeah.
Okay. And then, but beforehand, you've met the anesthesiologist. Your child has met the anesthesiologist because you've had some sort of a pre-op discussion.
Yeah. Before you mean going back to the operating room?
Yes. Yeah.
Yeah.
Like
Yeah.
before that
Yeah.
last part. Okay.
Yeah, because you'll at that point you'll have had to have talked about the anesthesia, had the ability to answer any questions, signed the written consent form for the
Okay.
anesthesia. So you'll definitely interface with the anesthesia at that point prior to saying your goodbye, your see you laters.
You see you later. And then so you're there when they're waking up,
Hmm.
as the anesthesiologist, and then the parent is not there until they're back into if they're getting admitted to the hospital room.
So a lot of times, so once the patient wakes up from the operating room, we will take them what's called the PACU, which is the post anesthesia care unit.
Okay.
And that is a place where they will typically have like a 1-to-1 or 1-to-2 nursing. And a lot of times the child will still be drowsy. And so they will allow the child to kind of wake up a little bit more. And then at that point, a lot of times parents will be allowed to see the child, like come meet the child in the recovery room when the child is like woken up a little bit, or after at least some time has passed and they've shown that they're stable. And that's usually when the parents will be able to kind of reunite with their child.
And is there any, like, when parents first see their child, is there recommendations, or as they're going out, like recommendations as a parent, like how you're saying, see you later to your child or welcoming them, are there different things you would recommend?
Yeah, absolutely. Like preparation for all of that beforehand. Like even with pictures, this is what the doors look like. This is where you can walk. And a lot of times, I'm also, I'm not a person who's going to be doing anything. Like I'm not doing any kind of pokes or anything like that. Very much a safe person in the hospital. So a lot of times, I will accompany them from that pre-op room all the way back to the OR during induction, and then I'm just kind of go. I just kind of disappear once they're asleep. But I'm that person, that continuous person that stays with them the
Okay.
whole way. But yeah, at the doors, and we're like, okay, there are the doors. We're gonna give mom and dad a kiss. We'll say see you in a little bit, and we do a hug, and they have their lovey, and then we go through the doors, and we continue to try to do that distraction, the coping that we've already practiced. And
Hmm.
then the same thing and then usually after that, as a child specialist, I go and check in with the parents. I'm like, hey, they're
Okay.
doing great, they're comfortable, they're sleeping. And then I kind of switch roles to then kind of supporting the parent and making sure that they're okay, because this is very scary for them. They're
Hmm.
very nervous. So just turning into that supportive role for them and making sure that they feel comfortable and they have somebody that they can go and talk to and be with, and then preparing them for this is we had like a check-in room, so they would sit in the waiting area. They would check in with the desk person. They would get the phone call when they could go back to the PACU, and then I would prepare them for what it would be like in the PACU, the parents. So this is what it will look like. This is who's going to
Hmm.
call you. This is what your child's going to be doing. They're going to be waking up, calm voice. We're just going to let them kind of wake up slowly. We don't need to do anything exciting. They
Hmm.
have, you can bring their lovey back to them, so they have that again when they wake up. And at that point too, I've also prepared the kid, if they didn't get the IV, when they wake up, they will have an IV in their hand. So when you wake up, it will be in your hand, because maybe when you went to sleep with a mask, it wasn't in your hand. So to wake up and have this thing in your hand can be a little scary. So we talk about that too.
Yeah, it really feels like preparation is just the ultimate key in all of this,
For
just with the
sure.
communication and the child and your care team, all of that. Yeah.
Yeah, lots of communication with, because I always want the parents to be a part of the care team, right? They're not just, everybody is a part of this team.
Yeah. Yeah. That makes a lot of sense. Is there anything, I guess, from your real life experience with your child going into surgery that you feel like you wish you would have remembered, or wish you would have been able to handle differently, that you maybe did better with the second surgery?
Uh, it's a good question. Both surgeries were in kind of very different times.
Okay.
His first surgery, he was in the NICU, and he was still recovering, and that was when we decided to do his G-tube surgery. So
Okay.
We had, that was obviously like that's like a big life moment. Like, you're kind of preparing for G-tube feeds. The second surgery was more, an outpatient eye procedure, so cylinder general anesthesia. I mean, I feel like I kind of have a little bit of a cheat code that I kind of know how both ways work. I help, mentally prime my wife and,
Hmm.
reach out to colleagues that work in the space,
Right.
and talk to them. So,
Make sure you know what anesthesiologist is on
yeah,
call.
exactly. But really it's just, getting to know us as anesthesiologists, I would say, we're present in a very short period of time in that person's life, but a very important time in their life.
Mhm.
It's a very scary time in their life. And so we have a short period of time to make a strong rapport with that patient.
Mhm.
And so that's what I try to do I don't know if this answers your question, but I mean, in
No,
kids,
absolutely.
I try to, it's like, hey, like, be a friendly face, answer all questions so that this parent who has only met this person in the last 5 minutes knows, okay, they're going to be in good hands, because ultimately it really is, do you trust who's taking care of your child, at the end of the day? And just because you trust them doesn't mean that, you should always ask questions. You should always advocate.
Mhm.
You should always push. There's nothing wrong with pushing and, getting clarification and, there's no such thing as really too many questions because ultimately, like, there's nobody that knows your child better than yourself, and there's nobody that cares about your child more than you do. And so, um, you know, if you have a team that, if you push them and ask a lot of questions and they're able
Mhm.
to answer a lot of your questions,
Mhm.
well, then, that reassures you that, hey, like these people, they know what they're doing, they know what they're talking about, they're going to take good care of my child. And then at the end of the day, like, that's really what matters most to me, at least.
Absolutely.
So,
Absolutely. That's awesome. Okay, I have one more question that I just thought of. But after your child is under anesthesia and they
mhm,
wake up, how long until I know we said, okay, it takes them a while to wake up and
mhm,
whatever, but if it was outpatient and they were to go home, how
yeah.
long is that typical or does it just depend on like what medications they've been given?
I mean, the boilerplate answer we give to everyone is within 24 hours, all the medications come out of your system, but
Okay.
it's not very helpful. Really, it depends on the child, it depends on the procedure, and it depends how long the procedure was. So if it's like a short procedure and we're able to kind of hold off on giving a lot of the long-acting medications, really within 30 minutes to an hour, I expect most people to kind of be awake, like kind of getting back to their
Okay.
baseline. If it's like a longer surgery, like a few hours, like multiple hours, and maybe like we have to give a little bit more pain medicine and we have to do a few more things, it can take a little bit longer for them to wake up and kind of be back to where they started.
Right.
Um, so but like an outpatient procedure, like you said, like simple outpatient going home. I mean, really like an hour or so is kind of my expectation,
Okay.
or
And
if not sooner than that.
yeah.
Yeah.
And as I guess just as a HIE parent is to the final would be, is there anything you want people to know about HIE kids or, the journey?
It is amazing how strong they are. It's amazing how resilient they are. I'm sure a lot of parents have experienced this. There's something different about reading your child, like reading the medical record of somebody, and they have HIE, they have developmental delay, they have X, Y, and Z diagnosis, and then you go meet the child in person, and they have this vibrant personality. They smile, they have things that they enjoy, and so. It really is amazing how much these kids go through and how resilient they are. I think a lot of people, maybe take them for granted or,
Mhm.
things along that nature. And so I'm always amazed at like, my how much my son has been through as a 2-year-old, that he's been able to persevere and, live the best life that he can live. He brings joy and light to our life every day. He laughs, he smiles. He's kind of feisty. He's a 2-year-old now, so he's very opinionated about things. And then, kind of to the parents, I would say like trust yourself. You really truly know your child better than anybody. If you feel like there's something off about your child, like don't let people tell you that everything is normal.
Mm.
Like we've had it in our experiences where you know, when he was young and there were some concerning symptoms, like, afterwards. And, we would bring it up and they'd be like, oh, we think it's okay for now. And we're like, we're not buying it. Like,
Right.
we go and you always have to advocate. Like, it's
Yeah.
just, I think everyone knows like the constant advocating battle, and that's normal, and it's just part of the process. But trust your gut. You know your child better than anybody. And then never stop advocating if you truly feel like, okay, I know there's something different about my child, and I feel like something needs to be done.
Yeah.
Because if you push hard enough, you can get people to move.
Yeah.
You
Yeah.
know.
Yeah,
So,
absolutely. Well, I mean, thank you for advocating. Thank you for being here. Thank you, for reaching out to us and wanting to support Hope for HIE and really giving parents, all of this wealth of information. And I think it's really important. And we need all of the caregivers and the parents, and your involvement is a really big part of advocacy on behalf of your child. So we appreciate it.
of course, I'm happy to be here. I hope for HIV. HIE is an amazing organization. It's been amazing to kind of see all these other kiddos and how strong they are and how resilient they are. And, I'm a member of the group. So if people have questions about anything, I'm just a message away. I don't, I'm very happy to take a message at any time and answer a question. I'm good with that. So
Right.
thank you all for all you do. Thank you for organizing this and
Yes,
putting it together.
absolutely. Now, is
The first question we have is about sensory sensitivity. So if your child has sensory activities, the question was, how do we prepare them for those sounds, smells, the environment in general in and around like the OR? And I would say that the hospital environment in general is very overwhelming and very overstimulating. So anytime you can prepare them for what that is going to be, especially based on whatever their specific sensory needs are. So you could go in to YouTube and type in pediatric pre-op and hospitals and see what videos come up, because a lot of pediatric hospitals specifically do videos of what it is like. So you can show them, oh, this is where we check in, and oh, look at these big bright lights. And so you can use certain videos. You can specifically look up your hospital and see if your hospital has anything as well. You can also make social stories, or I'm happy to help make a social story for any family. I've done that a few times. I had that in my emergency department that I worked in. When the families would walk in, I had a social story. It was all on one giant sheet, just of little pictures, so the child knew what was coming, what to expect, and kind of prepare them for that visit in the emergency room. So from that point on, they knew where they were going next, what staff members they were going to meet, what their role would be, what test we do initially, whether it's just the pulse ox and the blood pressure cuff, just all of those different things. And I had a picture for each one of those with a very brief, just almost like a caption for those. And then doing role play, medical play, again, preparing their senses. Oh, this feels really cold and wet, when they do the cleaner, or you practice with the anesthesia mask. It feels like a little soft pillow over your nose and your mouth. And of course, asking for your child life specialist when you get there, or even ahead of time, if you're talking to your care team, you can ask for a child life specialist to come and do some preparation with your child beforehand, and talk to them about their specific sensory needs, so that they are preparing them in the best way for your child. Are there preoperative tours or surgical spaces so my child can see that my child can see before that day? Some hospitals do pre-op tours. We did them briefly at my hospital for a while. It was usually a child life specialist that did the tour, because we are the experts in preparing children and knowing what their developmental needs are and focusing on their medical experiences. So you can, when you talk to your hospital or when you talk with your surgical team, you can see if they can do a pre-op tour. Sometimes they only do them like once a month. Sometimes it's every other week. It just kind of, it just depends. But I definitely think seeing those spaces beforehand can be helpful, because then it's just not more of a surprise when they get there, especially if it's their first time being in that area specifically. What comfort items or sensory tools are allowed in the pre-op and recovery? Typically in pre-op, you have your things with you. And so they can have loveys and, a pacifier or a book or a toy or a blanket or whatever those comfort items are that they need. That's usually all okay in that pre-op area. A lot of times they can take those back with them to surgery, and once they're asleep, those items are definitely like removed, so they're not in staying in the OR or anything, and then they can be given back to them in the PACU or in like post in recovery, so then the child has them again when they wake up. But again, this is all very it depends on the hospital. It depends on what each hospital allows. Every hospital has different rules on things like that. But in the places that I have worked, they can have those items in the pre-op area for sure. If your child has limited verbal communications, how do you help nonverbal or minimally verbal children express fear or discomfort? Of course, you would bring their communication devices if they use communication devices, or bring one of those All About Me sheets. You can also use our Support Spot app, which is free for all of our Hope for HIE families, that has coping plans on them. But as a person who worked in a hospital for many years, I loved having an All About Me sheet on my patients. You can put obviously their name, you can put things that they like, colors, movies they like, TV shows, who their favorite people are, what brings them comfort, what scares them, what just who they are as a person. What does their body look like when they're scared or when they're in pain? What does their body look like when they're happy and when they're excited? Like, all of these things help their communication, and the care team likes to know these things so we can take the best care of the patient as possible. So anything like that you can bring that would help communicate just your child's needs and what helps them would be wonderful. Can a parent be present during induction, and how do we prepare emotionally for that moment? That is definitely dependent upon each hospital and each, honestly, it's, I think, like we said previously, with the anesthesiologist, that is the anesthesiologist call. And I have workplaces where parents are present during induction, and it seems to work best when all members of the healthcare team are on board with that. It definitely can be beneficial, because that separation from parent and child is a very high anxiety provoking, stressful thing for the child and the parent both. But like I said, that's hospital dependent, that is doctor dependent. So that would be something you would make sure you would just ask that medical team ahead of time so you can prepare for that too. What was the other thing that we had? And how do we prepare emotionally for that moment? Sorry. So if you can be present, I think just practicing, preparing, giving choices, having a plan, asking for the child life specialist. If you cannot be present and there's a space where like you will be separated, as the child life specialist, I was usually in there in pre-op beforehand, and I was preparing the child for what was going to happen. And so I was a safe person. And we had developed some rapport, some trust. And so we talked about, okay, when we get to, mom's going to walk with us to here. And when we get here, we're going to give her a kiss and tell her we'll see her in a little bit. And I'm going to keep going with you. And we have your lovey and we have a game. And, we would keep playing, and I would keep them engaged and distracted and focused. And we would go ahead and do the separation. So letting them know ahead of time, like what we're going to do and what my plan is with them, was really helpful. And it's the same thing if you don't happen to have a child life specialist there, letting them know this is the spot, this is the place where I'm going to give you a kiss, and I'm going to tell you I'll see you in a little bit. And then when you wake up, you'll see me, and you're gonna, have your pacifier, your lovey, I'll give you your book or whatever the thing is. But again, preparation really is key. how do you help a child who may not fully understand what is happening or why? I think every kid, you meet them where they are, whatever they might need. So I would first talk with the parent and ask them, like, how does your child communicate best? What are their sensitivities? What stresses them out? Do I need to give them a lot of details? Do they typically not like a lot of details? So if I'm working with a family or with a child who can't communicate verbally to me or doesn't have a device to communicate, I'm going to get all that information from the parent. And then I'm going to continue to prepare them in the way that the parent suggests. So if they think, no, they still need to know everything, I'm still going to go through and I'm going to show them either pictures. If I have a pre-op book, I'm going to show them pictures of what's going to happen. I'm going to tell them who all the people are that they're going to meet. I'm going to tell them if things are going to be bright or if it might be cold and they need a blanket, if something is going to feel cold on their arm or they're going to have air in their nose called oxygen. Like, I'm still going to prepare them and tell them for all of those same things. You just do it in a way that they can understand and that's developmentally appropriate for their level. What does a typical recovery room experience look like, and how can we make it less overwhelming for a child who may be disoriented or dysregulated coming out of anesthesia? And that can be common for kids because you are waking up and coming out of anesthesia, but lowering lights so they're dim, just maybe quieting the machine so they're not quite so loud, having those comfort items there, having parents present. And again, I'm going to reemphasize preparation. So when you wake up, maybe they had the mask for induction, but when they wake up, they're going to have an IV. So you're going to have this medicine straw in your hand. There's going to be some tape. You will have oxygen in your nose. That's just a little bit of extra air. You'll see curtains. If the room is separated by, curtains, or it'll be a glass door. And I'm going to show you a picture of what the room looks like. So again, it's just about the preparation. So they know when they're waking up, because they'll be somewhat disoriented. Like, oh yeah, I remember hearing her say that I was going to have this thing in my arm. And I actually just had a conversation with a family about this. And they mentioned how their child, knowing ahead of time that when they woke up, they would have the IV, they weren't messing with it constantly. They weren't trying to rip it and pull it out because they knew, they were prepared that was going to be there when they woke up, because things aren't going to be the same when they wake up sometimes than when they fell asleep. And that's scary. Imagine not being told you're going to have a cast on your leg, and then you wake up and you have a big cast on your leg and you can't move your leg. Like, those are the types of things they need to be prepared for ahead of time. Are there any visual support, social stories, or pictures, schedules you can prepare in advance? Yes, I am happy to anytime make any kind of social stories or pictures specific to your hospital. They can always be general, of course, but picture schedules too. Visual supports, you can find videos, there's books out there. So I use a lot of things like that. So I'm always happy. I have a list of things that we've shared before, but I would always be happy just to give you something specific. If you need a specific surgery one, or you need something specific for your hospital, I'm always happy to even contact the Child Life team and see if they already have one that they've made that they could share. How do you support siblings or other family members present on surgery day? I definitely communicate, obviously, a lot with the parents. Siblings, if I would prepare them, I might be talking with them beforehand, but I will be honest, typically siblings aren't there a lot on surgery day because they're not allowed back in like the pre-op area or anything like that. But if I had a separate appointment with them, I would prepare them for sure. This is what your sibling's going to the hospital for. When they get home, this is what they're going to have. This is what they're going to need. They're going to need to be resting. So I would definitely be just preparing them for what to expect for you being gone, what was happening to their sibling, and then what it was going to be like when they got home, or how long you were going to be gone, and then what the plan was for the sibling that day. And as far as the family members, a lot of times I would, if I was the one accompanying the child back to the OR, once the child was asleep, I would go back and talk with the parents and tell them, they went to sleep, they did great, they did a great job. And then I would walk them to the surgical waiting area so that they could meet the check-in desk. They would get a phone call. I would show them where, just the cafeteria was, or where they could get coffee, or how the communication from the medical team or the operating room to that waiting room happened, and where the phone call was so they could check up on their child, or all of those things. So it was just really helping support the parents so they felt like they had all the information they need to stay in contact or know how to, how and when they were going to be seeing their child again. And then I just wanted to share a few questions that you could ask your medical team when you are preparing for the anesthesia, the OR. So a couple of them we mentioned a little bit, but am I allowed to be there for surgery? Will my child be sedated before anesthesia is given? So are they going to be getting anything? Are you doing like Versed or something like that beforehand? Will my child still have an IV in or be hooked up to any monitors or equipment after surgery is complete? And how soon after surgery can I see my child? So those are a few things you can just to keep in mind that you can always ask your medical team any questions, but those are a few that I wanted to share. Thank you.